So Bob emails, what do you say?
Yeah.
Anonymous annual patron, she says, I had my new favorite worst therapy session today. I've been shopping around for a while. So as a client, I think.
Right.
So I had my new favorite worst therapy session today. I disclosed my borderline diagnosis, and after asking a few diagnostic type questions from the therapist,
right.
She told me today was the day I was going to make a life change via positive thinking and to just push away the negativity. I told her I frequently feel suicidal and get depressed, and she reiterated that today was the day all of that was going to change through positive thinking. Apparently, she's been a therapist for over 20 years, and for 20 years, she's been about as therapeutic as a Reddit thread. Little does she know, I've been listening to Psychology in Seattle my entire adult life, and I'm not settling for that shit. Laugh, LMAO. Thanks for reading. Any thoughts on that, Bob?
Yeah, I'm the power of positive thinking. No, not a fan. So, yeah. Just based on what's written here, I would not have continued with that therapist.
Where do you think they were coming from?
Just the sentence, today is the day where you change your, that's just a little bit cult of personality, kind of forceful, sort of blowing smoke, like, nah, man, I think a little bit more humility is in order.
Yeah. Yeah, I've met people, and therapists included, who have this simplistic, dogmatic belief that thinking positive will solve everything. Can thinking positive help? Sure, yeah. Absolutely. Mm-hmm. Data shows that. I can attest to that.
Yeah.
And can you have a form of therapy that involves this? Yeah, there's versions of humanistic therapy. Mm-hmm. Positive psychology arguably is in this direction, but there's nothing good about any form of therapy, and no expert would recommend that you discount someone's experience, especially when they're pushing back a little bit, by just manhandling the client and saying like, well, you just need to think positive, essentially blaming the client.
Yeah, it's very invalidating.
For their problems and simplifying their problems to a simple choice to quote unquote think positive.
It is. It's so sweepingly dismissive.
Yeah. I mean, it's akin to someone's spouse dies and someone comes to therapy and you're like, you just have to think positive. I mean, that's literally what you're doing, especially as someone with borderline who has been through a lot of relational trauma. So
what's wrong with grieving?
Yeah. Now, having said that, if the therapist had said, well, here's my thing, and I get that you're going through this, and I understand, and I've been there for, suffering is real, and here's what I've found to be helpful if you would like to, this is part of that working alliance about collaborating on goals, collaborating on tasks. It's very important, is that for any client out there with your therapist, you should know either in a concrete way or in a mutual understanding way of what you are doing in therapy to meet the goal.
Right.
And you should also agree on the goal. And some people are like, well, I don't know. I feel like I'm a therapist that doesn't do goals or something like this. And I just think you're an idiot.
You haven't conceptualized what you believe.
Yeah. You can have a very floppy goal of, say, I'm here to help people grow. Okay. How do you know that you're helping someone grow?
Right.
I'm guessing you could literally just ask the client, is this helping you grow? And the client would say, yeah. And that's a goal.
Yeah.
And then you have to have an agreement on the tasks to reach that goal. It could be anything that you collaborate on in therapy. You could draw art. You could talk about your childhood. You could talk positive. You could try to think positive. But you have to have agreement. To just force a task on a client without the client understanding where you're coming from or literally wanting to do it to begin with is counter to the standard of practice.
Yeah.
But yeah. So, I'm glad that you, anonymous annual patron, were able to feel empowered enough to see through the bullshit. I think what you're saying is, given your life experiences and listening to this podcast, you deserve better, and you can tell when therapy is bad and when it's good, right?
Yeah, exactly.
Yeah, because so many people out there, they're just like, well, I guess this is what you do. Now, with this kind of task, might one do this sometimes in terms of helping clients to think positive? Yeah. Sure. I think it's a humanistic orientation that this therapist is operating from, of being in the here and now. And it can be kind of powerful that you try, at least for a time. It's kind of a mindfulness thing too, or what you focus on.
Agree.
That, okay, let's just take half an hour. And as intrusive thoughts or thoughts enter the mind that have to do with shame or past experiences or memories that plague you, notice them, don't fight them, but don't let them take hold.
Right.
Don't let them set up camp.
Right.
Just allow them to wash past you and then return to this other focus, whether it's breathing or nothing or a mantra or thinking positive or being in the here and now. Where am I? What am I doing? Am I sitting on a chair? The wind is blowing outside. It's sunny out. There's a lot of power in that, and that's a very humanistic idea, here and now, and it can help. But you have to explain it to the client. The client has to want to do it.
Right.
And you don't just forge ahead with that model. And also, you don't discount someone's feelings along the way.
I should hope not.
All right, next email. Patron Jenny from Minnesota, she says, would you ever be willing to talk about ethical dilemmas that people new to the field experience in early career years? Specifically, how to handle when you see superiors or colleagues doing things that seem to be lacking ethical consideration. Bob, just chiming in here, what do you think about that?
Oh, I remember being in a supervision or a group consultation at the clinic I used to work at when I got out of graduate school. And one of the therapists was complaining about the client that they just started with who has borderline symptoms and was describing the borderline symptoms like, this person's a pain in the ass. And you just rolled your eyes. And I said to them, well, yeah, but isn't that why they're coming here?
Oh, you said it.
Oh, yeah. Yeah, I said it kindly. I don't think it would have been useful or, it would not have been cool to attack, but to gently point it out, yeah, for sure. Yeah.
What did they do?
They ignored me.
Did anyone else acknowledge it?
Yeah, no.
Wow. Was the vibe of the consult? So this is how many therapists are in the room?
8.
And what was the vibe of the conversation? So you have these polar opposites. You have the person presenting that is being judgmental and not thinking. There's nothing wrong with being a therapist and venting for a bit, but you return to differentiation.
Yeah.
You return to the standard of practice.
Right.
But I've been there. I rolled my eyes because I've been there so many times.
You know this.
I can think of 5 moments in my career of that was exactly like that. Where I'm in consultation with other clinicians and someone is presenting on someone with borderline, whether they labeled it borderline or not, or something of this ilk, where it's clear from my perspective that what they're describing is the client has relational traumas, is being triggered in various contexts, including therapy, including by the therapist, and the therapist doesn't see it and is either having countertransference or just out of ignorance.
Right.
They react as if the client is not a client. They, like a typical example that's kind of extreme that will be provided in academia would be you have a borderline client who threatens to sue you, for example. Right. That doesn't happen very often, especially if you manage the relationship well. Yeah. I mean, as someone that specializes in people with borderline, I don't know if anyone ever threatened to sue me. But you talk to the average clinician and they'll be like, oh yeah, all borderline people will threaten to sue you. Oh, yeah. I've had borderline clients that were threatening to sue other people. So I'm, it's not like, but if you manage the relationship well enough and you know what you're doing, then the triggering that was involved didn't get to that level, I guess. Right. Anyway, someone will be talking about how, well, maybe let's downgrade it. So, someone in consultation will say, yeah, I have this client who has some suicidal thoughts sometimes, and she also will cut at times. She has a history of that. So, I'm starting to hear some signs, and her relationships aren't going well. And so I was trying to help her, and she just folded her arms and said that she didn't want to talk to me anymore. And I did my best to try to tell her, like, look, I'm just trying to help you. And she just stormed out of my office. And so, this is bullshit. Like, she's obviously not ready for therapy. And I don't know why she even came into this office. End of story. Yeah. And I'm thinking from my position, I'm like, is it possible that the reason why she's in therapy was played out before you.
Right
and,
there.
Yeah. And all you had to do was show that you cared,
Yeah.
you know, and that you're a safe person, like, in spite of her being triggered, you know, did you not learn that fundamental of change? And it's more that than the opposite, right? I mean, in your DBT group, they would all understand, obviously. They understood borderline.
Yeah.
But in a non-specialized rabble of therapists, I would say it's 90% of the time, if someone presents on someone that has a personality disorder, it will go like that, right?
Yeah. Yeah.
Yeah.
Yeah. Yuck.
Yeah. So what patron Jenny is asking is, how do you handle, well, have you ever seen a superior or a colleague doing other unethical things that would pique your, the possibility of reporting them or talking to them?
No. I mean, I might disagree with somebody and they might be judgmental. I don't think that rises to the level of reportability.
Right.
It is definitely something to be addressed. Like, come on, we got to change. But people like,
it could be argued though that it is reportable, or at least, you know, the way that we're taught is, and it says this explicitly in our codes, is that you go to unless it's something really egregious,
right,
you go to the clinician first and give them an opportunity to change. And then if they don't, then you go to their superior or the state licensing board, depending on the situation, of course. But so I would say that what you did was trying to help that clinician in the moment.
Yeah.
I was surprised that you did that, because I usually am too afraid to say anything.
Oh, yeah.
Because I don't trust the room. Like, you could argue in that moment that you just harmed your relationships with at least that person and maybe other people in the room.
Maybe others, yeah.
By trying, and it doesn't change anything, and it just hurts you.
Yeah.
You know what I mean?
Right.
So that's usually the call that I make, is like, now in today's mind, given my position, I probably would. I would hope I would.
You probably would.
But in the past, I didn't have that power.
No,
I didn't have that
me
political
too.
power. I
Yep.
didn't have that
Right.
clout. And so I would just be gritting my teeth and digging my fingernails into my hand under the table. You know, you could argue it was an ethical violation, or something unethical was happening when you're...
Something, yeah. It's not okay.
Yeah. Because it is a primary principle within the ethical code to benefit the client and to be competent in your job. And that person was exhibiting neither of those, right? But have you seen anything else that, you know, like where you're like, whoa, I need to report that person?
Oh, nothing.
Like sex with a client or...
No, I've never seen that.
Bad paperwork?
No. Well, the paper... No, I never seen that either.
Confidentiality breaches? I've seen that. I've seen people do that.
I have never seen that. No, I haven't. It's funny, I haven't.
Huh.
But don't get me wrong, I wasn't happy with the degree of professionalism or competence among the therapists at large at that agency. Like, I didn't think that... I have this perspective now that the general vibe of the place is overwhelm and burnout, and people were behaving in ways that are consistent with overwhelm and burnout, which means that there are lapses in areas where there ought not to have been.
There's a difference, though, because you and I can be overwhelmed and burnt out and vent and upset and lose empathy temporarily.
Yeah.
Or we know we're having a hard time accessing it. We still know that compassion is there. Yeah. And we know in the moment, at least at times when we're having that burnout, that we're in a state of burnout.
I think that culture permitted it, which is one of the reasons I'm very grateful that I left.
What do you mean?
I think that there was a certain level of entitlement to misery and to whatever fucking consequences that is on the world around me, so be it. And I think I see this in good clinicians. They simply hold regard for their client as central, period. Right? So venting, frustration, burnout, all part of the thing. But those just get talked about as problems to be solved, not as like, oh yeah, you have a right to that and we'll just leave you there.
Yeah. What do we blame for that? What's the cause of this?
When I think about that place, I think it was run poorly by people who are interested more in their success than in the well-being and welfare of the business end of that got overemphasized. And so they would squeeze as much out of the therapist as they could. They were funded, and the whole thing, I think, was set up for that to be the case. And so a degree of misery and cynicism grew and pervaded. And I don't see that in other organizations, even ones that like aren't so well funded, because there's a dedication to a mission.
Well, yeah, I think so. You were in that scenario. You were being squeezed as a labor.
I was.
And you were overwhelmed and maybe burnt out at times, but you still kept your eye on the ball.
I made a deal with myself. I said, you are a volunteer here. You get to, this is what you get. You get a paycheck in exchange for clinical hours, supervision, move towards licensure goals, and an opportunity to work with people in a way that you want. That is a fair exchange. You don't have to like the paperwork. You don't have to like the paycheck. You don't have to like the bureaucracy. You don't have to like the attitude, but you are a volunteer. You are not a victim. And that was a really important shift for me. I think I adopted that about a year or two into working there because I didn't want to fall into that nonsense.
I'm trying to understand. Are you saying that the shift in perspective was that you said, okay, look, I'm here to get paid to do a job, and I'll do that job. And I'm another thing, which I volunteer to actually help these people.
Yeah, that.
Okay.
I was a volunteer there. I was not, nobody made me do that.
You had to add this other inspiration or identity beyond what was being modeled to you and what was being emphasized maybe by the organization.
Yeah, otherwise I would have crumbled.
Right. So why did you do that and the others didn't?
I don't know.
I blame culture, mentorship, and teachers and professors. So I have seen this where you will have a professor who it's almost like there are different pedigrees or something.
Oh, I like that word.
You know, I would see a professor as a colleague or even as a student, and they would be of that sort where they didn't have that compassion, that deep dedication to humanity. Mm-hmm. It was a job, and the clients were, at best treated as people that you cared for, sort of, but average baseline, the clients were kind of an annoyance, Yeah. And and sometimes the clients were ridiculed, maybe even globally, clients sometimes, or they're always asking for more shit all the time. They're always calling me, and when you have a professor like that and the students are being mentored along those lines and not inspired, because it's tempting, it's stressful. Community mental health is very stressful, unfair to the therapists and the clients for that matter. It is. And it's not the fault of the mental health agencies, it's the fault of the politicians and by extension the voters for not voting for politicians or pressuring politicians to allocate funds or raise taxes to pay enough for these services such that the therapists can, instead of seeing 42 clients a week, maybe they only have to see 30 clients, which would still be hard, but it's a little bit more handleable. Anyway, so they're overworked, and I get that, but and you want to vent about it, but if you have no mentorship, so you're getting that from your professor, and say, just by the luck of the draw, all your instructors are either like that or they don't exhibit what we're talking about. Then you go to your agency, and luck of the draw, most of, if not all, of your supervisors and colleagues are also like that. So you don't know any better. You don't know any different.
Yeah.
I also think that some people get into the field for a very different reason than you and I got into it.
What, for the money? I'm kidding.
Yeah, maybe. Or for the prestige.
Really?
Or because they didn't know what else they wanted to do. Yeah.
Huh.
Yeah, I've met some, and that can be a good thing or a bad thing. It can be a bad thing in the way we're talking about. But I have someone that I know, a colleague, a psychologist who does CBT only, and getting to know the way that he sees the world, he recognizes that there are therapists like you and me, and he values that, and he thinks it's great. But for him, and he hopefully tells his clients this at the beginning of therapy, that he is there to do a model of therapy, and if the client doesn't want to do it, then they don't want to do it. And he doesn't want to learn anything new, and he doesn't want to get into complicated areas. He just wants to provide his worksheet-based cognitive therapy and behavioral therapy, and finds that that's good enough for him. And then he goes home from work and he doesn't think about therapy ever. He just, does other things, and it's a job. It's fine. It's like any other kind of thing that you do. Like maybe accountants are similar. It's like, yeah, it's fine. I go to work, I do my thing, and I like it, and it's okay, and I go home.
Right on.
So I think that there's those people. But anyway, so for you and I, we must have had, and I know we did, people who mentored us and taught us and influenced us in the way that we are. And then you and I go on to influence other people. Because in my supervision groups and individual supervision, and in my case consultation class, I was adamant about this understanding and the shift, because of course the interns would come in and start complaining about their clients, which is fine and venting, but I would always really take the time to walk not only the individual intern and supervisee through, but also the group, to have everyone go, okay, understand. And I might even be explicit at times in terms of what we're talking about now. There's nothing wrong with being burnt out. It's normal. There's nothing wrong with venting, but you became a therapist because you wanted to help people, correct? Okay, then you have to find a road to compassion. That was my big thing. Yeah. It's like, find the road to compassion. And I see you have not found that road yet. So let's figure out that road. And that road typically resides in your heart and in your conceptualization. Yeah. You have to have faith. You have to have love to give. You have to want to hand yourself over and be open as a therapist. And you have to be smart enough or consult enough so that you have a way of seeing what the client is doing. Because, it's easy to be compassionate for a cute 7-year-old kid who likes to draw and laugh and play games. Like, it's easy, right? It's hard to have compassion for someone with a personality disorder who's attacking you or attacking their family members right in front of you. That's when it becomes challenged, but you have to find a road to compassion. Right. And if you can conceptualize it, it doesn't excuse what the client is doing, but it does provide a way of seeing that they're operating from a place of vulnerability and being triggered and relational trauma. And it also gives you a path to treatment. At the same time of finding a road to compassion, it gives you actually what you should be focusing on. Right. It gives you a road to change. And that was a lot of work. I would have supervisees that would push back. There's some notable supervisees that I can remember over the years that would get upset at me because I was, to them, invalidating their feelings, telling them that they're wrong, so to speak. I wasn't saying that, but that they were wrong for being angry at their client and giving up on their client. They felt like it was righteous for them to, quote unquote, draw a boundary with, quote unquote, inappropriate client behavior. Wow. Yeah. And if they weren't with me and they were in the case consultation class next door, they might have actually received none of what I'm saying and received encouragement to be doing what they're doing.
Ugh, gross.
Like there's a whole, so that pedigree of the lineage of your training and exposure, if you never had someone that thinks, we come from a pedigree that had enough of what we're talking about that inspired us and solidified us and dedicated us, and we see it, we notice it when it's not happening. Yeah. Other people come from a different pedigree.
I had a teacher, you remember Dan Gallagher?
No.
Oh, he was the teacher on my side of the program. And I took a class with him. He was lovely. guy. He's probably passed on now. He used to work at Western State Hospital with children, and they were using behavioral management for kids with autism. And so that included corporal punishment, which was not supposed to hurt the kid, but was supposed to provide, a negative stimulus or whatever. I don't know how they call it. But he said one day he went to spank this child, and the child gave him, it was
as a clinician, he went to go spank the child.
Yeah, that was actually the behavioral program, is that they would use spanking. So this was in the 60s. This was or 70s, a long time ago. And this is the cool part of this story is the kid made a face. This is a kid who he was nonverbal, right? And Dan Kelleher saw the face, and he gently turned the kid around, and he took down his pants, and he saw that he was injured. And he said, I turned the kid around again, and I could see a golden light coming from his heart. And we stopped doing that.
Makes you cry thinking about it.
Yeah. I don't come from compassion.
Right.
And
your dad chose not to, or had a hard time seeing that golden heart within you.
Yeah. Yeah. Good guy, but ill-equipped to raise 4 children. And anyways, the whole thing. And when I think about what I could have been, when I think about what's in me, I am so blessed to have met a guy like Dan Kelleher, who somehow found it within himself to wake up, or at least just see what's around him. And Marsha Linehan, hardest she was to work for, exuded that toward her clients, and you, and my old supervisor, David Taylor, and Lillian, and all the people that taught me. And my own therapists who love me. I am so lucky because I have that in me. I could be like that, rigid and hard-hearted and all that shit, and I fucking don't want to, but I coulda. And I could have languished in a community mental health clinic feeling jaded and righteously indignant about my own victimhood. And I don't know how it happened, but I remember the day I became a volunteer at that job. And for 4 years, I continued to work there. And I just didn't give a shit about the paperwork and the bureaucracy. And it was still annoying, right? And still difficult clients.
Did you have any colleague that was sharing your point of view? Or were you isolated and alone?
No. There were several, like Noelle, my friend Noelle, my friend Molly, my friend David Kersey, who was the psychiatrist on that team, and just one of the loveliest humans I've ever met.
Did you and I talk about this? I'm sure we did back in the day. Do you remember any conversation?
I don't remember you and I talking about it. No.
I feel like I've always been this way.
You have.
Yeah.
There's
evidence. I don't remember thinking this specifically, but the fact that early on in my career, I was working with a fair amount of intensely borderline clients, and working well with them must have meant that I didn't give in to the temptation of giving up.
Right.
Yeah.
Yeah.
But I don't remember specifically talking about it. I do remember having some internal clashes and not saying anything in consultation back then. But yeah, that's beautiful.
Oh, I remember that too.
What?
In fact, when I was in case consultation in graduate school with Pam, who I love, Pam Hayes, just great. I watched people give judgmental advice. And, you remember this, the book recommendations. Oh, well, have you read this book? Well, you tell the story about what happened with your client, and they're like, oh, well, here's this book you ought to read, blah, 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 blah. It's like damn fucking New York Times book review, some bullshit, right? And books that I'm never going to read. Can't even remember the titles.
Yeah, look, there's nothing wrong with saying, hey, I don't know if this is going to help you, but I read this book that kind of has to do with what you're talking about.
Right.
And here's the name of the book. Obviously, there are other books out there,
sure,
and there are other roads to learning what to do. But I'm just going to throw it out there, a tentative thing. But 99% of the time, what they will do is they'll say, have you read this book? And you will have never heard of it before, because why would you have? And then they'll say, like, you've never heard of this book before?
Oh my God.
And then I'm like, no, should I have? Especially early in my career, I'm like, am I some sort of idiot for not knowing this book? And it was never it was a big book to that individual, which is fucking fine. But, don't act like it's this gift from God that this random author wrote a helpful book for you, And then they'd be like, oh, well, you really have to read this book. Oh, okay.
Yeah.
So
great.
by implication, I'm an idiot for not knowing this book exists. I'm an idiot for not having read it. All my problems can be solved by reading this book. And if I don't read this book, I'm irresponsible as a clinician. Thank you.
Yeah.
That's so helpful.
Yeah, exactly.
And that's all they have to say.
That's it.
Like that's their
saying,
piece of advice. Yeah.
Hey, good job on this, or let's be supportive of you on that. So I remember we would write papers in that class periodically, and I wrote to Pam. I'm like, I am not saying another word unless I have something positive to say. I'm not going to participate in
Wait,
this.
why'd you say that?
I didn't want to be one of the sharks swimming in there biting at people because they hadn't read the book or whatever. I mean,
you noticed that people were tearing each other down.
Yeah, right. And I wrote to her and I'm like, I'm not saying another word unless I have something positive to say. That is it.
What did Pam say?
Thank you.
Oh, so she noticed.
She wrote it on my paper. She's like, thank you.
She noticed the negativity.
Yeah.
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 Yeah. Well, going on with email.
Right on.
I have had many experiences working in residential treatment facilities, both kids and adults, that seem to be very unethical. Physically restraining kids without legitimate cause for intervention,
right.
Paying a client for something they made, giving clients special treatment and privileges, going into clients' rooms without consent or authorization from the mental health professional, and there were no safety concerns present that would warrant this, making accusations without evidence and finding out that they were wrong and not making any attempts to apologize or mend the relationship, and telling clients where the cameras and telling clients where the cameras can't see them. Oh.
Whoa.
Meaning that the clinician is talking to the client purposely where the clients can't see them?
Or telling them, here's where the cameras aren't so that you can get away with shit.
Oh, okay. Every job I have had in the field, I have seen people doing shitty things.
Yeah.
I mean, just chiming in here, I don't have that much experience with inpatient, but I will say that everything that we've said thus far is amplified by inpatient because it is even... it's 10 times more stressful than what you and I are talking about. The burnout is 10 times worse. The underfunding is 10 times worse.
Right.
The clients are extremely challenging and present behaviors, not often, but can be violent and can be concerning. So it really amps up the issues, right? It doesn't mean that people should be allowed to be unethical, but
No.
But, there's another factor, too, that I don't know this, obviously, but anecdotally and intuitively, or it makes logical sense that of the people who enter the general mental health field, there's a reason why you and I have never worked at an inpatient.
Oh, I have.
Oh, you have? Right, right. Before you were a therapist.
Yeah, a long time ago.
Right. Well, there's a reason why once you had the option not to, you didn't work there.
Oh, there is.
Yeah, because... like I said, it's underfunded. It's stressful. It's hard. It can be demoralizing because a lot of times the clientele are such that they're not necessarily going to get better over time,
right?
And it's not very fulfilling, right? And depending, right? And so the people that land in those jobs, there's a higher proportion of people that were already burnt out or are working there out of necessity because they can't get a different job or something, or they're not qualified to work in other arenas.
Right.
So you have the stress, you have a staff that when they felt the calling to enter mental health, this is not the sort of job that they thought they would end up at, right? And so it causes people to be stressed out, and people, when they're burnt out, will start cutting corners. And, ethics... 99.999% of good ethical decisions are made when the clinician knows there's no consequence to doing otherwise. You and I, all of the decisions that we make in the client's interest are self-generated, and no one on the outside is going to tell us to, and if we didn't do those things, no one would tell on us. The client might not even know that we're doing something that's wrong.
Right.
So we are self-policing in a very real way. Our ethical codes are self-policing.
Yeah.
It's not an outside agency. When you come to a stoplight, you stop. You're not self-policing.
Right.
You have been told by an outside organization, the government and the police force, the law enforcement, that you must do that.
Yeah.
And if you don't, then they might consequence you. For us, we do have a licensing board that can consequence us, but the vast majority of how we police ourselves is through self-policing.
Yeah.
We police each other, and we invent our own rules. We invent our own standard of practice. We establish that, and then we require ourselves, to follow it. And so if you are in an organization where people aren't super dedicated to the field and don't have that internal germ of, I am here for a higher purpose than just working here. There's a bigger reason, a spiritual reason, if you will.
Yeah.
And that, if that's not really present, then, and you could get away with these things, then why not, right?
Yeah.
Why would you work harder than you have to, right? So I think that's one of the reasons. And I don't want to paint inpatient as all one thing. There's a lot of different types, and there's obviously a lot of different people that work in these places. I know someone that worked at Western State Hospital, like the person that you do, but they worked there their entire careers for 50 years.
Wow.
And very compassionate psychiatrist and a good guy.
Yeah.
And I don't know the specifics of his work, but he cared.
Yeah.
Not in the way that you and I do, I don't think, but a lot, like a grandfather, a father figure. So it's not like everyone is like that.
Yeah.
Also, there are a lot of people that enter inpatient treatment that it is temporary. They had a temporary spike in suicidality, or they went off their bipolar meds and they just need to get put back on, and then they're fine. So it's not like everyone that enters those places are, very rarely will they be violent, but the fact that it's a possibility at work is stressful, you know, and the staff are often under supported, where you literally just have a tech guy, and you're just like, well, you're the biggest tech, you're 6'2",
right, 250
pounds,
right.
So when Joseph over there has an episode, it's your job to actually wrestle him to the ground. Like that's not
some shit.
Yeah. So it's difficult anyway.
Yeah.
I mean, I had a friend who was in that position as a tech, and he told me the story about how he got isolated in this room with a known patient who was known to try to kill people.
Oh,
and
scary.
He somehow got tricked to being alone in a room with him, and the door was swinging shut, and if it shut, it was going to lock, and he wasn't. So he got, he tried to open the door, and they ended up in a wrestling match, and he was desperately trying to keep the door open,
right,
so that he wouldn't literally be killed by this guy, and it's that kind of thing.
Oh, that's frightening.
Yeah, and he's being paid like, a little bit more than minimum wage at this point,
right?
So anyway, going on. I am starting to realize really how barren the land of good mental health workers is. I mean, just chiming in there, if you're basing, Jenny, from Minnesota, your experience in inpatient as a representation of the entire field of mental health, that's not wise to do.
Right.
Maybe it is a wise thing to conclude regarding inpatient on average, you know what I mean? Certainly, like I said, there's a bell curve, but I am currently only a bachelor's level individual, but will be going on to my master's soon, similar to what you did.
Right on.
It makes me really sad to think that we have so many good mental health professionals, but the people working the floor and spending the most time with clients on the unit are often wildly flawed in what good mental health practice looks like. How do I handle it when I see superiors and colleagues doing things that seem to be lacking ethical consideration, Bob?
Well, I mean, you're probably really limited in your degree of power, and you have to survive in a place that may not change much. So pick your battles, and you might decide not to do anything to stop the stuff. Maybe you decide what's egregious to you. Okay, great. And what you're willing to risk your job for. Okay, fine. But you can't swim upstream and make the river turn backwards.
Yeah. The thing that popped into my head, and maybe this is not possible, but to find a person with more power than you.
That's a great idea.
That you can explore this with.
Yeah, that's a great idea.
there's
who you can trust.
Yeah, there's probably a clinician who's thinking similarly to you,
Probably.
or at least is open to it.
Yeah.
And if you could bond with that person, and that person will be able to do something much, and be able also to interpret the ethical codes
Right.
better than you can. And so then you would just use them and say, I saw this. So, and maybe they would work with you on how to report, but
Right.
to just be flailing on your own as a bachelor's level person, it would be hard to get anything to change.
Yeah.
You know,
You would get, and you could easily get yourself professionally or actually employment-wise shunned.
Yeah. And thought about, I mean, well, they could fabricate things against you, and
Right.
Who knows? It's kind of unknown as to how safe you are.
Right.
Let's take a break. We get back. Let's try to kind of do speed round, because I was hoping to do more emails. What do you say?
Sure.
All right, we're back from the break. Anonymous patron, she says, what are your thoughts on inpatient psychiatric facilities? I am a clinician at a pretty small hospital. One of my units is an inpatient psychiatry ward, and I find it to be such an uncomfortable place. I wonder how much we're helping patients versus how damaging this environment can be for them. I'm curious about your thoughts on inpatient psychiatric facilities. Well, we've already talked a bit about it, but anything more?
I'd say you're going to have to keep your sights proportional to the environment. Most people that are in an inpatient psych unit are there either because they've had a psychotic or a manic episode and they're a danger to themselves or others, or because they're having suicidal crisis. So the goal of these places isn't to cure anybody's mental health. It's to stabilize so that they can leave and, live in a least, what do they call it, the least restrictive alternative or something like that. And it's out there where the bigger changes that I think the person who wrote in is thinking of, it's out there where those will take place. So if it were me, it's love who's there while they're there.
Mm-hmm. Yeah, and I imagine to be successful and to like this kind of venue to work, you have to be a nerd for that kind of clientele.
Yeah.
There's some people are.
Yes.
They're a nerd for people with schizophrenia or bipolar.
Right.
Or suicidality.
Right.
And they really get a lot of satisfaction working with that population, and they have a lot of compassion for those people.
Yeah.
And they're okay with the occasional client that has more, severe behaviors.
Yeah.
They frame it in a way, they welcome it. They're saying, I'm going into this knowing that this is a part of the job, and I'm okay with it. In the same way that for you and I, Bob, when we specialize in personality disorders and treat people with borderline, we accept, and this is part of my mentorship and supervision of novice clinicians, is that this decision has to be made. I'll walk through it in my supervision stance or my supervision position because it's easier for me to describe. So I'd have a supervisee who would be describing a client, and I would wonder if we're dealing with some sort of cluster B, whether it be narcissism, borderline, or histrionic.
Right.
And I introduce the topic and say, remember all that studying you did in previous class about psychopathology, or that very limited exposure to the section on personality disorders? Well, now's the time. So let's get into it, and let's do some assessment. And next time you meet with that person, I want you to ask these questions and to look for these kinds of things. And then over time, we discover, the client, maybe even I could just ask the supervisee in that moment, do you see this? Do you see that? And then I would start zeroing in on a conceptualization of, let's say, histrionic or something. And then I will say to the clinician that, because often what they're telling me in the supervision meeting is that the client is attacking them or something like this, as being frustrating, very, very frustrating, very triggering to the therapist. Mm-hmm. And I say that's normal. I go through the same thing. It's an indication of cluster B when you have those feelings. It's par for the course. It's normal. You can't have someone with moderate to severe personality disorder in this category that doesn't do that to you. Yeah. And you are at a Y in the road. So you can either right now say, you don't want to work with these folks, and we can go down a road of figuring out how you're going to screen these sort of clients out before you meet them, which will be hard and limiting. I'm going to tell you, you can do it, and I'll support you 100%, but I'm going to judge you a little bit for that, because I value and have a value, that a true therapist is someone that loves everyone and does the work to help those people who need the help most, which are these people.
Yeah.
We did not enter this field just to work with the easiest clients.
Right.
You know, if you're a cancer physician and everyone that has a more advanced cancer and you give up on those people, what kind of cancer physician are you?
Yeah.
You know what I mean?
Right.
So I'm not going to lie, but I'll support you, and I'm not going to downgrade you as a supervisee.
Right.
I'm not going to punish you, but internally, maybe a better way to put it is I'll be sad for you and for your career and for clients if you make that choice, but it's your choice. You can do that.
Yeah, sure.
The other direction in the why is that you will go down a very difficult road that I have been going down my entire career, and others as well, that involves wrestling with your countertransference, having a very robust conceptualization of clients, having a very robust self-care system and consultation and supervision. You will make mistakes because you will get triggered. They will push you. There are risks. The client might sue you, that these things will happen. So it's hard, it's difficult, but the rewards are so great. The amount of benefit that you can give a client that needs so much help is so great. I mean, a little bit goes a long way with these folks. I mean, just giving them a tether to love and compassion and relationships, and someone that's not exploiting them can ground them in a way that they've never been grounded, But it's not going to be easy.
No.
But I'm going to be with you, and you're going to come to me next week, and you're going to say, you're wrong. This client isn't ready for therapy. You're going to and other people are going to tell you that. You're going to consult about this client, and I'm just going to tell you, idiots are going to tell you that this client isn't ready for therapy and that you need to terminate with them. You need to draw boundaries. And certainly that's your choice, and I'll support you if that's your call. We can figure out a way, or they'll tell you to refer the client or something,
Yeah.
And I'm going to tell you that is not the way. That is not the way to help this person. That's not the way to developing as a clinician. The lessons that you will learn with this client will be life-altering. Yeah. Not only for your career, but for your life. The understanding, the wisdom, the love, the compassion, the meaning, the purpose that I have found through this crucible, I wouldn't give that up for the world. So, which is it?
Yeah.
So, that's a hard thing to do, and so when you enter inpatient treatment as a clinician, it's a parallel why in the road. Do you accept that 1 out of 100 patients here are going to lash out violently or are going to threaten that or something? Do you accept that your clients are going to come to you when they're at their worst and leave when you've helped them to get a little bit more stable, and then other people will pick it up where you've left off? Do you accept that there's going to be a lot of stress and people aren't going to value what you do, and some of your colleagues might have some ethical problems? Do you accept that? Do you if you have a mentor that's really helping you to do that? And if the answer is no, I don't want that, then you probably shouldn't be working in this field. But
it's not in that environment.
Yeah. But for many people, the psychiatrist that I was referring to, he obviously said yes to that because he never complained about anything. I mean, he had a patient show up at his house that I think escaped from Washington, from the hospital, and tracked him down, and in the middle of the night, like 3 a.m, was banging on the door. Actually, I'll just say it's Umberto's stepdad.
Oh, really?
Yeah.
Oh, fantastic.
And Berto was there in the house.
Wow.
When this happened. Anyway.
Trippy.
So let's take a break, and we get back. More emails, what do you say?
Yeah.
Okay, we're back from the break. Patron Elena, she says, "Hi, Dr. Hanna. Thanks for your insurance rant in the reaction to John Oliver." So I made a series of episodes reacting to John Oliver's show where he talked about insurance and mental health, and I was agreeing with a lot of the thing. I was expanding on what John Oliver was saying. Mm-hmm. Here's how insurance recently screwed me over. Blue Cross audited me. So for those who don't know, Blue Cross is a health insurance firm in the United States, and they provide, health and mental health insurance. Blue Cross audited me, which I have no issue with, and dinged me for not recording stop and start times. So just chiming in here, this is a clinician, Alina, who is maybe paneled or whatever, using this insurance with at least some of her clients. And that insurance company audited her practice. And she's saying, I have no issue with that, but they dinged me for not recording start and stop times. So,
you mean like the session started at 1 o'clock and it ended at 1:53?
Right. Like you need to have an exact, I've never seen that before.
I've never seen that before either.
Yeah, I've never seen that. I listed procedure code with time spent with each client. Yeah. Which is
right there.
That's standard.
The procedure codes are.
Why would you need more detail than that?
They're time descriptive.
Yeah. But they wanted start and stop times, even though I received nothing indicating this was a requirement. And they revoked payment for all sessions in the audit totaling $3,000.
That's just a scam.
Yeah. I appealed and spoke to my state psychological association and the American Psychological Association. They thought it was ridiculous, but wouldn't do anything.
Oh, man.
One lawyer even told me that, well, they've had to pay out a lot more for mental health with increased demand and accessibility through telehealth during COVID. Oh, so
yeah,
I'm guessing what the lawyer is saying is, look, the insurance companies are bleeding money right now.
To them, they're bleeding money.
Yeah. And I get that, because when you have a capitalistic based health insurance, you have the need for profit. Otherwise, you will literally go out of business as a health. It's like if you're a restaurant and the price of bread goes up, you have to raise your prices. And so if suddenly everyone is now utilizing a service that was not as utilized before, you are now bleeding money and you might go out of business. So you have to do something until you can start raising rates later on when people re-enroll, because you get locked in on a contract. You know what I mean? So I get that, but you shouldn't lie and do illegal things and screw over clinicians who are just trying to make a living. You know what I mean?
Well, what would happen if they just said, no, I'm not giving you any money back? Was the insurance company going to spend money on lawyers to track that down?
I mean, insurance companies, if you're in private practice and you're by yourself, I would not advise that someone go against what the insurance company.
No, they're such a behemoth. They have deep pockets.
They can destroy you.
Yeah.
Unless you have a lawyer that you believe in that says that refusing to pay them back might be a good thing, because then you can go to court and then we can win and put an end to this bullshit. Or I don't know.
And also they'll make them pay for your legal fees, whatever it is.
Right.
That's a risk that probably for $3,000 I wouldn't take.
Yeah, right. Totally. And Alina says, your assessment was so spot on in the reaction videos to John Oliver. In my state, we have very good mental health parity laws. Just chiming in here, meaning that there were laws passed that said you need to have parity between health and mental health. So, in that the benefit you give the customers of your health insurance, say, we pay for 80% of medical procedures. Well, you also have to pay for 80% of mental health procedures, which was not the case in the past.
Right.
But if they aren't enforced, these parity laws, then this is what happens. Mm-hmm. I know several providers who now don't take insurance because the audits were so absurd, which of course is what the insurance companies want. Yeah, that's too bad.
Yeah.
Blue Cross in Washington is actually great. They don't do any of this shit. But
I never heard of anybody getting audited.
Yeah. But I could imagine some insurance companies in Washington doing that. I mean, that's another annoying thing. It's like every state has its own system of health insurance companies. Yeah. Like every state has when I would call Blue Cross, for example, I would have to find the specific Washington office for Blue Cross.
Right.
Anyway, so in Washington, the shady insurance companies are United, massively shady. They pulled out into first place years ago. So the second place is pretty far from them, but other second place people are people like Cigna. Or Aetna. So yeah, that's pretty awful.
Yeah.
And this is why, one, you either need laws and regulators, it's great to have a law, but so, you can have laws saying don't run a red light, but if you don't have any police officers that are enforcing it randomly to keep people honest, then people are just going to run red lights, right? You can pass a law that says corporations can't pollute the environment, okay, but unless you have a regulating body that actually monitors that and takes complaints and actually punishes and has the legal power to punish these corporations, then it's just a fucking law.
Yeah.
It doesn't mean anything. And the way that you have these regulating bodies with power is that it's through taxes, it's allocation of funds. And when you have Republicans that are dismantling everything because they have this ridiculous dogma that government doesn't do anything and government doesn't help and smaller government is better, this is what you fucking get, people. So knock it off. All right, another email. Annual patron Crystal from Canada. She says, my name is Crystal and I'm a nurse from Canada. Oh.
Right on.
This podcast is the only reason I am still here today.
Oh.
Both you and Bob's therapeutic approach is flawless in my eyes.
Oh, wow.
And I am so thankful for what you do. I acquired PTSD while working in a pediatric operating room.
Oh, wow. Yeah.
This has resurfaced sexual, physical, and emotional abuse I endured from early childhood into young adulthood. I've been off work for a year and a half under care of my province's insurance program, which forces me to work with one of their selected psychologists to continue receiving financial support. So just chiming in here. Yeah, it's interesting because as Americans, as I was kind of ranting earlier, we tend to think that our health system sucks and that Canada's is awesome, right?
Yeah.
And when I actually hear from Canadians, they will say, well, there are some things that are better, like we don't have to pay for a lot of things, but it's not perfect,
Right.
People in Europe will say the same thing.
Sure.
They'll get put on these long waiting lists going on here. A few months ago, I made huge progress with exposure. So exposure therapy, I'm guessing.
Yeah, right on.
My therapist was overzealous with progress and moved forward too quickly, exposing me to extremely triggering event. Okay, a few months ago, I made huge progress with exposure. So that sounded positive, but then it sounds like the therapist was not doing it correctly. While it was happening, he realized he messed up and completely shut down during the exposure and left me with little explanation or answers to what was going on in his head. He admitted he messed up a few weeks later, which is good, and didn't assess my a few weeks later, I didn't assess my triggers properly. Since then, the relationship has been devastating to my mental health. When I heard Bob talk about his experience with attachment theory, I felt understood for the first time. When you discussed transference, the relationship with my therapist made sense. I got the courage, so it sounds like Crystal might have had a similar experience of the disorganized attachment feeling of wanting desperately to be close and have secure attachment and have attunement and being really preoccupied with that at the same time as being terrified of being harmed by people that are close to you, and then to have the therapist actually harm her. And so since then the relationship has been devastating to mental, so it sounds like maybe a lot of triggering and a lot of preoccupation with what's going on between her and her therapist. I got the courage to bring up both my suspected transference with my therapist and how I felt insecure attachment was a roadblock for me and our therapeutic relationship. He essentially gave me his definition and acknowledged these things can happen, then moved on and didn't address it further. So what do you think about that?
A missed opportunity. Yeah, right. I think that acknowledging the thing is insufficient, and I'm kind of thinking, geez, what would it be like in the moment after that, and we don't take it any further? How awful that would be. How abandoning that might feel. Just yuck. And how it might actually not be workable. I mean, if the guy made a mistake and can say he made a mistake, great, that's good. If they can talk about transference and attachment, whatever, and acknowledge that, okay, great, that's cool. But that's not sufficient. Now what? The now what is really where we're at this point. And if just based on what we've heard so far, it sounds like the therapist isn't up to doing much with the now what.
Yeah.
Fuck.
I wonder, given the the trapped nature that Crystal is in, because she has to work with one of their selected psychologists to continue receiving financial support.
Right.
So I wonder if there's an avenue to getting this psychologist educated. And Crystal, I don't know how you manage that, but the fact that he apologized gives me hope.
Yeah.
And maybe he just hasn't had a good mentorship or education or something.
Yeah.
So maybe if you were to have him listen to the episode that you heard, or you just kind of lay it out for him or something. I don't know. That's ridiculous that you have to help him with that. But, there are other, in terms of just how fundamental this should be in our field, that every therapist should understand it. But there are other things like that. I'm trying to think of can you think of a time when a client said, I think you need to learn about X?
Yeah.
What was X?
ADD.
Okay.
Yeah.
And what was that like?
That was back when I worked at the clinic. They weren't wrong, and I also didn't have the bandwidth or the interest. That was back when I got assigned cases, not based on what was interesting to me or what I wanted to do, but because, I had an opening.
So the client was coming for ADD.
ADD treatment and behavioral treatment.
They just gave the file to you, and
they suggested that, I think that Daniel Amen book. Yeah. So yeah. My supervisor just gave me the file and said, "This is your client."
So you'd never had any education in ADHD?
No.
Never supervision?
No.
Or experience?
Nope.
Yeah.
And no interest.
Right.
And, you work in a place like that, you probably have to learn as much as you can about a lot of different things, even if you're not interested, if you want to do a good enough job. She wanted me to read that book. I think I tried to read it, or I started reading it. Then, or was it later? I don't know which.
Well, I can't imagine one book really doing the job.
Yeah,
it's pretty complicated.
Yeah.
And anything else, like, because there are a number of things, like if someone this would have happened early in my career. If I had a black client, for example, and they were talking about family and upbringing, they might suggest, or I might know, that I need to become more familiar with themes that are common for black families growing up in that area, for example, so that I can have some background in terms of what the context was, or how to interpret certain stories that they tell me, or something.
Yeah.
And without that, so there might be something like that where a client comes to us, and the client might even tell us, like, I want you to learn about X, Y, and Z.
Right.
There's nothing wrong with that. And, therapists should be open to that and humble about that.
Humble. Yeah.
Yeah. You don't want to be a dick about it as a client and say, like, you're an idiot as a therapist, but you can just be like, hey, so there's this kind of theory or this style of therapy that I have known about, that this podcast talks about, or whatever.
Yeah.
And I don't know if this would be useful for me, but I wonder. And if you were to know about it, then maybe we could talk about it, that kind of thing.
Right.
So going on here.
Yeah.
I believe he is driven largely by his ego, approaches everything with extreme logic and very little empathy, and stays within his box of CBT with little desire or interest in expanding the alternative approaches.
Now that bugs me, because good CBT therapists do understand about alliance. They're not technicians that just, I will now apply exposure therapy. They actually have to understand alliance well enough in order to...
Yeah, but...
You don't think that's true?
No, it is true, but I use cognitive therapy all the time. I use behavioral therapy.
Sure.
Exposure is behavioral therapy.
It is, indeed.
I also understand other aspects of humans,
Yeah.
that cognitive therapy and behavioral therapy doesn't really explain, So there's nothing wrong with cognitive behavioral therapy. There is something wrong with ignoring aspects of humanity.
Exactly.
Yeah.
Like a good medical doctor I think it's incumbent on a good medical doctor to have some good interpersonal skill.
Yeah.
Because you're not just there to treat the sprained ankle or,
But it might be beyond that, though. It sounds that, but it might be beyond just bedside manner for this therapist, because there are two areas that from the description sounds like this therapist is deficient. One is fully understanding the pacing of exposure therapy.
Yes.
And a lot of people, I would venture to say the majority of people that I've come across anecdotally who know enough about exposure therapy through trauma-focused CBT or even CPT, even EMDR, that the majority of people I come across anecdotally will not fully appreciate how you have to tailor it to the client, and you have to be really careful, particularly with some clients who have been through a lot of trauma.
But that's so fundamental to doing it properly so that it actually helps.
But trauma-focused CBT is manualized for 10 sessions for everyone.
Yeah.
I think cognitive processing therapy, CPT, another manualized protocol, is similar, maybe 15.
Yeah.
That's fucking ridiculous. Well, I've had clients where they need 3 years of therapy to even begin to think about exposing themselves.
Yes, of course. The research, though, for those treatments are not on folks with this kind of complexity.
Right.
They're on simple stuff. And it's fine because, but you only learn a little bit. I remember my friend Katie being in tears one consultation. She was a DBT person at the clinic over there at the UW, and she was in tears because the client had a huge complex history of trauma and the exposure therapy isn't set up for it. And I remember my friend Melanie saying to her, we actually do not have treatment that's sufficient to the level of trauma that this client and many, many others are suffering. So let's just do what we can. And no doubt, knowing what I know about Katie, she would have paced it properly and also been very clear with the client up front. So
you're saying that she was being advised to give up?
No, quite the opposite.
Oh.
She was being advised to hang in and recognize that as a profession, we don't have a therapy that's designed to help with complex PTSD. At least we don't have a CBT therapy that's designed to help with that. So,
I mean, I think it can be modified fairly easily.
Yeah.
You just have to wait until,
right.
You just have to stretch those 10 sessions out over 10 years.
Right. Those clients were research subjects, so they would get a year and then the year would be up. And so it's fine. It's research though.
Yeah.
So there's a pro and con to that. And the advice was to just do what you can.
Yeah. I mean, one of the things that I see is that there's well-meaning efforts to find evidence-based treatments for a particular thing like PTSD, and they develop something like trauma-focused CBT.
Right.
And they base it on sound science.
Yep.
And they develop a protocol, and in their effort to get funding and also to limit the amount of money they have to spend because they don't have the money to spend, they have to limit it to simple PTSD. And they also screen out people that have confounding or comorbid issues like suicidality or a personality disorder, which is bizarre because,
it is a bit it's very artificial.
But fine, not every study can be that inclusive. Okay,
right.
Fine. And then they run the study, they find what they find, they report it honestly, but at some point beyond that, the researchers possibly as well, in order to promote, because if you are at the spearhead of that research, your entire career might be made by that research. Because, if you're a research professor at a major university and this is your thing, then literally all year long, you are involved in several studies with a number of different colleagues and graduate students. And in order to retain your job, in order to get famous, in order to get more funding,
right,
you have to be charismatic and you have to sell like a car salesman.
Yep.
And so you go to the public, maybe even when you're interviewed on CNN or something.
Right.
It's like you're Elizabeth Holmes trying to sell Theranos or something.
Oh, it's not quite like that.
Well, it's in that direction, though.
Fraudulent. She was just lying through her teeth.
That happens, though.
No, I get it. But a good researcher, they have all those constraints that you're describing, but they also are doing ethical work.
Yeah. Well, there are some that aren't, but
There are some, of course
Yeah,
there are
yeah,
some,
yeah.
but a good researcher is still going to have those constraints.
and they're motivated and pressured because they're not just free to
they're
research.
not. Exactly.
They need to come up with a shtick that will get them the funding and the job. And there might be a lot of employees they have.
Yeah,
or graduate
exactly.
students. And so when they talk about it, they're incentivized to downplay that there are a lot of clients that present with PTSD that this model will not work for.
They can't talk about that.
Or the findings of this study will not apply towards because they limited the participants in such a restrictive way because they had to. And also when you involve other disorders, it muddies the water. And, it's like when you're trying to study the hardness of granite, you don't want to have other rocks in there.
Yeah, no.
You want only granite in there. Otherwise, it's going to mess it up. So it's a similar principle.
Research is just toeholds.
Yeah.
It's good. It's also not climbing the whole mountain.
Right. So then you have a bunch of people who believe the hype that trauma-focused CBT is. And the other thing is if you're trying to promote a book or it's your lecture series or your program at your university, then you also will downplay other models. You will promote yours. You might even find research that says the other models don't really work. And then if you don't know what you're doing and you're a student or a clinician or a journalist, then you just believe it.
I know somebody that did that, and I don't know how they sleep at night. I'm not going to name them.
Oh.
It's gross.
Meaning they demeaned other models?
No, they promoted their own despite the fact that there isn't any evidence for it. I'm not talking about who, not a DBT person for whatever it's worth, but
to thousands of people?
Internationally.
Yeah. Oh, yeah. That happened. There are a lot of charlatans that we could name.
And I don't even know if they think they're lying. I think they're telling the truth. I think they're just lying to themselves.
Well, because they're incentivized to subconsciously go in denial. We understand this, right? When someone is drinking every day, there is an incentive to deny that you have a drinking problem.
Right.
When you are trying to make a living and all you have to do is go into denial about something, then you're going to do it. So
humans are basically self-serving.
Right. Especially when you have a system that funnels people into denial, essentially. So then you have all these people that drink the Kool-Aid and they believe it.
Right.
And then you have all these clinicians that just force this model on people without any kind of critical thinking. And there's not a lot of people out there, not a lot of programs or professors who can contextualize everything. I had some professors, I talked about Bill Heusler in a previous episode, and he would do that. He could tell us about the research, and he was evidence-based, but he would also zoom out occasionally and say, well, but you have to ask yourself, what was the research privileging in the methodology and in the reporting?
Good question. Love it.
Like, what are they emphasizing and what are they leaving out? What are the constraints on the researchers that influence how they're saying this? What isn't being addressed? What are the things being left out? We don't know if that's a fruitful exploration, but it's worth exploring.
If you don't at least read it critically, like with that in mind, you're going to miss the boat.
Right. But so that's one thing, is that you might be able to help your therapist extend their knowledge a little bit by understanding pacing, like to be a good, to be a good CBT therapist, it's not necessarily what we're seeing here, the bedside manner issue. It could be that the person doesn't really understand the principles that TFC, BT, all the other ones are based on, and isn't utilizing those facts when tailoring the treatment to the client. So that's one thing, which is very common. The second thing that the therapist doesn't seem to understand potentially and might be hostile towards is the idea of attachment to begin with.
Yeah.
Because if you're fully drinking the Kool-Aid about CBT, depending, but you will hear adherents to CBT that will talking about the past is a complete waste of time. You'll hear CBT therapists that will say, if you go to therapy and the therapist talks about attachment or childhood or whatever, they're a Freudian therapist who is scamming you for money, because they know that if they keep you in therapy a long time, just rambling about your childhood, it'll make you worse, or at least just keep you the same. And guess what? They laugh all the way to the bank on that, or they're in denial of the reality of evidence-based therapy. I mean, so we don't know, but given that you're trapped, Crystal, I might, run it up the flagpole and say like, actually, maybe just have him listen to this whole segment. Actually, Crystal, but you can absolutely. He doesn't have to. You could actually use your time in therapy and just make him listen to this whole thing. And by the way, if you are listening, dear therapist, we're making a lot of assumptions. So, feel free to email in if you have a rebuttal, or if you need help for that matter. But just reading the last bit here. Yeah. I'm at a loss. Let's see. His response was that he was sorry he couldn't help more and speed things up, and asked if I would like to increase sessions to twice a week or decrease to once every 2 weeks. So yeah, I could see the wisdom of doing either. If you can get him to do the right kind of therapy, then twice a week might be helpful, and it's nice of him to offer. Or if you're just like, well, I have to see him in order to get funds to survive, then reducing to once every 2 weeks or even lesser might just be what you do. I don't know. Going on. I'm at a loss of what I can do or where I can go from here. I feel he has given up on me or does not care. Is there anything I can do to try and steer this relationship and or treatment into direction where I can regain hope? Well, I feel like we already addressed that. I wouldn't assume he doesn't care. He's a human being. So if he has a road, if I could just download Bob and me into his head, and he would just have this like if I was to use a visual metaphor, like you have a carpenter who is being tasked with fixing a chair, but he has no hammer. He only has a screwdriver. Right. And he doesn't know a hammer exists. And he's trying to fix the chair, and you're like, how come you can't fix the chair? And eventually as a carpenter, you're just like, maybe it's unfixable. But you hand the carpenter a hammer and you show him how to use it, and he's like, oh, and then now he enjoys it. He's like, this is the answer to my life. Like, oh my God, this tool, I've always wanted to help in this way, and now I can. Right. So it's possible that that's the key. Yeah. Crystal, I think the only answer is to have him listen to this segment. Because I can't imagine you, Crystal, explaining this to him. Do you know what I mean?
He might not hear it.
Yeah.
Hey, hats off to Crystal for hanging in.
Yeah.
Like really hanging in. There's a thread through the whole thing of like interest in the therapist.
What was that?
It just sounds like Crystal has interest in the therapist. It's like, not just like, oh, I've got an axe to grind, they're a big jerk face, blah, 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 but actually wants the thing to work. It's really cool.
Yeah, there's a easier path along the lines of what Bob is highlighting, which is that you could just subtly engineer the conversation. It sounds like exposure therapy might not be advisable until you get reassurance that he knows how to pace things and how to monitor things. You could also kind of force him, because it's up to you whether or not to enter exposure. Scratch that. So let's put exposure aside for a second and talk about your relational traumas that you're recovering from. There's a possibility that you could you go twice a week or once a week and just say, and maybe he has a bit of time where he checks in on homework for cognitive behavioral purposes, and you do it. But then after that, you just kind of ask him questions and develop a relationship, maybe even literally just asking him like, what do you think about me? Like, do you care about me, or what, or just talk about your life. And if he's a good enough listener, like maybe it's good enough as a corrective experience or something. You know what I mean? That's possible. I did a similar thing like that with a supervisor once who was very CBT, by the way, just I think coincidentally, who every time I presented a case to her, she would say, okay, what kind of skill should we help the client with? Like no matter what the case was.
Man.
And it was always skills. And in the beginning, I'm like, well, surely this isn't her reaction to everything. But after a while, it was. And I was later, into my career enough to know that this was bad supervision. Right. And I would but she had power over me, like she could consequence me negatively if I don't play ball. So
you didn't have any choice. You needed to work with her.
Yeah.
Yeah.
So I played ball for a bit, but then as soon as I could, I would transition to making it as useful as possible to me, which I think amounted to me talking about cases and then her mostly giving very fishy and very dubious advice or something. But it gave me a chance to contrast what I think might have been helpful based on what she was saying. You know what I mean? Like, I was like, well, internally I'd be like, well, that's dumb, but that's an idea, but I'm not going to do that. Just sort of learning what not to do.
Yeah, right. Yeah.
And also having a chance to kind of clarify for myself or something. You know what I mean?
That reminds me of this poster that used to be on this donut shop my dad and I would go to when he was taking me to work. This is right after I got out of high school. And it said, everybody that comes here makes us happy. Some when they arrive and some when they leave.
So what was that again?
Everybody that comes here makes us happy. Some when they arrive and some when they leave.
Yeah, that's exactly what I'm talking about.
Right.
Yeah.
Shit.
Yeah.
How long did you have to endure it?
Maybe a year.
Ooh, that's a long time.
Yeah. Weekly.
Yeah.
Maybe less, but it was a slog, I mean, it's a perfectly nice person and it was never harmful to me or anything.
Yeah, right. Just not helpful.
But yeah, just a waste of time.
It could have been harmful if you had, hook, line, and sinker. Oh yeah, we'll get into the skills here. I like skills. Skills has a place.
Oh, it could have harmed me, right, if I let her convince me that that was the only answer that a therapist should be asking. Yeah. So, Bob.
Good luck, Crystal.
Yeah. I have something to tell you.
Oh, what? Uh-oh, what?
That's the last email.
No way.
Yes.
The last one? We don't have any?
No. Well, Stacy probably hasn't populated the Google Doc with recent emails, but that's the last email.
Holy cow, it's never been the last one.
No.
I thought we would just be sailing and never see land.
Maybe, Bob, the podcast is over for good because there's no more questions.
Well, what are we going to do on Mondays?
We'll talk about skills. And that does it for that episode of Psychology in Seattle. Everyone out there, please take care of yourself. And if you want Bob and I to answer a question, say it up front. Say this is a question for Kirk and Bob, because then Stacy knows explicitly to put it in this document. And take care of yourself because
you deserve it.